To meet this strategy, we have to start getting more into the community. So because we want to influence the lifestyle of the community, because indirectly it affects the outcomes, the health outcomes, right?
Hello, everyone. This is Cole from the American Journal of Healthcare Strategy, joined by a special guest today from Rush, Anil. Anil, can you please introduce yourself and your role?
Yeah, thank you so much. My name is Anil Saldanha. I'm the Chief Innovation Officer for Rush. Rush is a 3.5 billion health system in Chicago. So we have three major hospitals, a medical college, college of nursing, and graduate college offering various healthcare management courses. We also have outpatient centers in the Chicagoland area and Northwest Indiana. We are one of the 20 hospitals on the US News Honor Roll for a few years now, and we have many specialties which are highly ranked in the US. And yeah, we've been ranked by Vizient on quality for many years now. We've been in the top five system for quality for many years. In terms of my role, I focus more on healthcare innovation, and I also act as a strategic advisor to our C-suite on issues involving transformation, innovation, things like that.
Thank you so much for coming on, Anil. It's a huge honor. One of the largest, third largest city in the United States, and one of the, if not the largest, kind of institution there, and doing some really incredible things. You got your start in computer science and engineering, software engineering. You've had very prominent roles and some great success. You've been started off as a software engineer before I was born, and you've continued on with great experience. You've been director of engineering, vice president of engineering, senior vice president of engineering. You were previously the chief cloud officer, so very well regarded in the software engineering space. And then there's the transition to kind of innovation at Rush. What got you to want to work in healthcare and in the innovation space? How did that come about for you?
So I would say, as I got trained in engineering and software in my early part of my career and my life, over time, I was also fascinated by the business side, and I used to, be in the Silicon Valley during .com and in the late '90s. So I've seen the highs and lows of technology, but I also completed a business program at Berkeley, Cal Berkeley, when I used to be in the Bay Area. So that's when I started, getting more fascinated on the business, solving business problems. And technology, it's great to solve a lot of problems in the world. And I started getting into tech as part of my training and professional life. But eventually, as you gain experience and you start looking at the world through the lens of business, you start seeing problems, and over time, I started getting more involved in, I would call, the verticals, on the business side. um, One of the first areas that I kind of got into exposure to healthcare was, I think I was working at a company called Red Hat. I'm talking about the years like 2006 and 7, and I was very involved in something called patient consent, directive. So patients should have the ability to control who can see their medical records and stuff. And one of the partners we were working back then, as part of an industry standards consortium efforts, there were interoperability at HIMSS and others, was Department of Veterans Affairs. So they were trying to solve this problem, for their veterans. I don't exactly recall, but that was I think my first insight into some of the challenges healthcare has. I was involved in some standards work with the VA on like patient privacy and stuff like that, and I did get an opportunity or exposure to what do you call emergency preparedness at the federal level during the anthrax crisis we had, I think, around 2006 and 2007. So it wasn't something that I like actively pursued. It just happened as part of my work, and over time, it's I've ventured into other areas in terms of big data, cybersecurity, and I think I'm thinking like maybe around 2015, I had an opportunity to apply some technology in advanced technology concepts to healthcare in the field of genomics at a company called Tempus here in Chicago, which just went IPO. And this, I would say, this opportunity basically opened my eyes to healthcare in general, but the latest and greatest in like things like precision medicine. So I was able to like assist with setting up like DNA sequencing labs, RNA labs, things like organoid modeling labs, and of course, precision medicine, and also got to exposure to various cancer centers. This happened in the last few years, and this also brought. I mean, this was at a startup, with high growth. What do you say? Strategies and workflows and stuff. So it also got me exposure into the entrepreneurial side, exposure to venture capital, as private equity, and so I built relationships over time in the industry. And of course I had like my technology, I would say, experience and expertise, but with my business, I would say, like parallel education, I started looking at, okay, let's try to solve problems. And about, I would say, 3 or 4 years ago, I got this opportunity at Rush to lead a what do you call a CDPH data hub, Chicago Department of Public Health data hub that they had just built in. So wherein you brought in clinical data from 15 plus hospitals, labs, and once the vaccines were approved, you brought in all that information from the state for all the vaccination that happens in the city of Chicago. And this system was primarily put in for what do you call disease surveillance, pandemic response, and that's what got me into Rush. And at that time, I think it was a cloud-based system. So that's why my title, I think, was probably the first chief cloud officer in the industry. And it was more like it's situational and like the need of the hour. And over time, like once the pandemic started subsiding, and I started like, okay, still fascinated by solving the healthcare challenges that exist with my business background and technology background and my connections with the entrepreneurial community. So I felt and our leadership felt that innovation is an area that is suited. And in my opinion, it's still a learning process. Healthcare is not always known for innovation, but increasingly, we're seeing a lot of efforts across the industry, which is also brought up with advances in things like artificial intelligence and the latest and greatest, in terms of medical devices,
Mhm.
algorithms, and things like that. So there's been a lot of innovation in not only in technology side, but also on the process and methodology side. And we have a lot of problems to solve in healthcare. So in my opinion, I think I'm at a good cross section of technology, business, strategy, and others, to look at healthcare problems and challenges, um, and try to bring in solutions.
Absolutely. I mean, it makes sense when you explain it because what you're working on now, I mean, you've been working on AI and the learning models, value based care, health equity, those kind of private and public partnerships. I mean, these are all things that you've had now, that we go through it, years of experience doing. one of the challenges is, Chicago has health access and health equity issues, right? I mean, there are 14, or 15-year life expectancy gaps between neighborhoods. The Chicago Department of Public Health, I'm sure you've experienced it while working there or working with them. They have 500 vacancies, right? I mean, 40% of their positions are unfilled. And so it's a challenging environment. How are you kind of strategizing, around innovation and strategizing within the organization on how to address some of these problems? And what do you see are the major problems that you're trying to address?
So there is an official term that we have coined in the last, I would say, 10, 15, 20 years. So I'll give you an example. I mean, you mentioned the life expectancy gap, and I want to kind of quantify it a little bit. So if you are in Chicago, you have uh, the Michigan Avenue, which is like our the most famous avenue we have, where we have what you call a magnificent mile, and we have Streeterville and some of the affluent regions of Chicago. So if you're visiting Chicago, we always suggest take a look at Michigan Avenue. There's the Water Tower, and um, the Wrigley Building, and we have Millennium Park, and so we have some of the attractions. So when one of our leaders um, and did some research a few years ago, they noticed that, like, if you're born and brought up in a region surrounding Michigan Avenue, which is like an affluent, you will live 16 years and growing longer than four subway stops on the west side. Like, literally four subway stops, you live 16 years less as compared to someone who was born and brought up and works in
Wow.
on the Michigan. So we coined it, this phenomenon, as Chicago's death gap.
Yeah.
So there's a book that our chief health equity officer has written. It's called Chicago's death gap. So basically, a few years ago, so we identified these age discrepancy issues. So this, we are talking about just the west side of Chicago, and we have similar challenges on the south side of Chicago that University of Chicago Medicine is addressing. So when we talk about this death gap and the patient population or the community population, we're talking somewhere in the range of like 500,000 people.
Wow.
So it's not a small number. So I've heard like 500 to 700,000. So it's not a small community of people. So the primary challenge is this age discrepancy, and so Rush, I would say around 2015, around that, made health equity as a strategic priority. So we instituted something called a anchor mission network. So we created like playbooks for community health equity and stuff. So this highlighted some of the concepts, like try to hire locally, invest locally, build locally, and also operate locally. So this whole concept of community health was kind of given prominence at Rush in terms of corporate strategy. So
Yeah.
I wouldn't say that we tried to push health equity heavily, but I think, in my opinion, Rush was one of the first health systems to actively talk about health equity. So you see health equity being talked about by CMS, the public agencies, and the payers are also talking about. Uh, but health equity as an issue has been there for a long time. And in terms of the strategy over time, as an institution, we have excuse me, we have tried to invest locally, and I can give you some examples.
Yeah, and can you also maybe contrast what the opposite would be? So, if we think about investing locally, what does the opposite of that look like? What does investing unlocally look like?
So, I mean, when you look at, I'll take a step back and explain. When you have a health system such as Rush, they are heavily focused on what you call delivery, right? You're looking at care delivery, and you're built like a delivery system, and your ecosystem is there. On Rush, one of uh, the philosophies we have is Rush sits at the intersection of public health, community health, and delivery system. So we cannot heavily focus on delivery systems. So when I talk about delivery systems, it's about operating, taking care of the patients who come into a system, and with health systems expanding across your local regions, sometimes across state lines. That whole entire strategy kind of dilutes, if you think about it. So that whole sense of community, local, kind of slightly dilutes when you start having an expansive strategy. So
Mm,
I mean, this is how the industry is operating. In terms of focusing locally, like I said, the communities we serve, I mean, it's a large population. And with this death gap, or life expectancy discrepancy, we have identified as an institution, one of the strategic goals we had is we wanted to lower this life expectancy gap, I think by half, by 2030. So it's an aggressive strategy. So to meet this strategy, we have to start getting more into the community. So because we want to influence the lifestyle of the community, because indirectly it affects the outcomes, the health outcomes, right? So
yeah.
as you can see, as the official term is like social determinants of health, with housing, transportation, utilities, interpersonal safety, things like that. But things like education, employment, they are also equally critical for a community level, to improve the outcomes of basically a community.
Hmm.
So in my opinion, that's the difference between focusing heavily as a system on care delivery, and the expansion of that strategy, and looking at patients who come into a system, um, uh, when compared to, like, you try to influence the health of the communities you serve by getting close to the patients where they are. Traditionally, when you look at health systems, you had this, I mean, I'm talking about, like, I don't know, 10, 15 years ago. The entire culture of folks were like, oh, you are sick, you start driving to these big buildings, as you can see, in somewhere in the downtown, or adjacent to downtown area. But now you're seeing this heavy kind of a transition in the industry towards what you call ambulatory care, and you have like outpatient centers popping in, because the industry itself shifted from an inpatient mode to an outpatient, like an ambulatory setting. It was just because we had the pandemic. Right before that, we had the younger, like, population coming in, who was like tech savvy, and consumerization of healthcare started becoming popular. The US federal government started pushing something called price transparency. So a lot of factors kind of influence this delivery model. So you went from inpatient to an outpatient. So basically, you as a system, you're going towards where the patient are, and that's the right thing to do, to be honest. So that is, I mean, one of the biggest challenges we have had is access. Imagine, like, people who are struggling with transportation and jobs and stuff. If you're working 2 or 3 jobs, you can't expect them to, like, start driving to a downtown area to get their tests, or get for care or follow-up care, whatever. So that entire model needed to be shifted and broken down, and I'm glad to say that systems across the country are looking at outpatient centers. And like, as an example, we just built like a cancer center, not only in downtown but also in a suburb, to bring in like, the latest clinical trials, and screening, and advanced treatment to the population in the suburbs. So Russia as a system is building some of the specialized centers, um, to basically bring access to people.
This episode of The Strategy of Health was sponsored by Modality Global Advisors. Modality Global Advisors optimizes hospital revenue, enhances patient experience, and delivers proven results. Visit modalityglobaladvisors.com to learn more. Yeah. I get the access part. I think I have one question. As a public health advocate, I'm definitely on the attitude that hospitals being involved in the community is a good thing. There's some pushback from that from some administrators I've spoken with off camera, and they say that they feel like financially speaking, it isn't the system's job to be involved in the community, and it's too financially precarious. Now, with Rush seems to be doing fairly well financially after we reviewed some of their reports, as well as a lot of other hospitals who are involved in their community. But I wanted to ask you, have you seen return on investment? Have you seen improved outcomes and maybe even improved savings from being involved in investing local?
Yeah, it's a great question. So recently, I was involved in a roundtable discussion on health equity, and one of the assertions I made is health equity doesn't have to just be good for patients. For as a system, you can. I mean, I wouldn't say that should be the primary focus, but you actually can derive operational savings when you start doing good in the community. I'll give you some examples. So, like I think few years back, around 2019, 2020, Rush partnered with a medical supply company out of Ohio. I think it's called Concordance or something. It's something with C. So it's basically a medical supply company, and this is before we started having major challenges with medical supplies in recent times. So we collaborated with this company to start, what do you say, building like medical supply centers on the west side of Chicago, right?
Hmm.
And this not only brought in a little bit of efficiency savings for Rush. I don't have the exact numbers, but all I can tell you is certainly provided jobs to the local community. And when I said if you have community that are looking for jobs, right? I mean, like these are, let's say, decently paid jobs in a meaningful area, which is medical supplies in this one example. uh, and then it kind of influences indirectly the community, the families, and so indirectly we influence the healthcare outcome of the community. So this was one example. So it did bring in some cost savings from an operational perspective. So this happened a few years ago. Then in most recent times, I would say in the last 12 months, Rush used to send their linens, their uniforms for cleaning purposes, like the laundry services across state lines.
Mm.
And we are talking about not like 10 miles away. It was slightly longer across state lines. So we worked with a laundry service to build, like basically a facility was built in the community, and Rush gave the contract for linen and basically the entire laundry. And we I think the estimates were something around the range of 700,000 cost savings per year.
Wow.
But I also want to say um it also provided jobs for between 300 to 500 people in the community. And these are like well paying jobs. And on the west side, Rush is, I think, the major employer. And when I say employer, I mean, we're not talking about, okay, this laundry service. We actively employ people at our system from the west side. For example, we actively train students. We provide them coaching and mentorship in high school. For example, we bring them to have a glimpse of how healthcare as a system works, and look at the jobs, for example. So we have various programs, community health engagement programs, and I think the official program, it's called Reach. So this is primarily focused on high school students. So we have mentorship sessions. So we want to work with the community. So I talked about the medical supply, I talked about the laundry. We also worked with our community partners on. We just broke ground, I think, a few weeks ago on something called a wellness village.
Hmm.
And Russia's philosophy is, if you want to influence the health of a community, you know start providing primary care clinics, for example, right? We've also been stating that start you know building like basketball courts,
Yeah.
right? When you think about healthcare, it shouldn't be like sick care, it should be healthcare.
Right.
It should be an holistic treatment of the community. So food, fresh food is a major requirement. Access to primary care, access to like cancer screening, for example, maternity care, things like that. Like, it kind of negatively affects some of our communities, like Latin, black and brown communities. So by focusing heavily on community partnerships with the city of Chicago. So we have broken ground on something called a wellness village, wherein you will have like a wellness center. We look at recreation. We look at I don't know, like things like yoga, and provide a place for like teenagers to spend some time getting some kind of mentorship. And so basically you build it in the community. So this is it's called the Sankofa Wellness Center. Rush is very excited about this. So these are, I would say, like uh, the major investments we have made with partners in the communities, and we've been a major player in some of these initiatives to basically influence the health of our communities, and also indirectly bring this life expectancy gap down that I mentioned at the beginning. I also want to mention, I'll take a minute about, I would say, in the last 3-4 years, we also worked with other health systems, community partners, to build this collaborative called West Side United, which operates around, I think, 10 zip codes. So basically, look at like some of the social aspects of healthcare, and work with organizations, community-based organizations, faith-based organizations, health systems in the region, including Cook County, UIC, Rush, I think Loyola, and others, to basically help the community health of this. So Rush has been a major player in establishing this collaborative. It's called West Side United. So again, it kind of works on the philosophy of established that when we take care of the community, we have better outcomes, and in general, it's good for Rush.
I really like the kind of macroeconomic or regional economic approach to this, where it's money that we have to spend because we have to have clean linens, we have to have medical supplies, all these things, and now how can we create jobs in the community, spend get tax dollars generated in the community, and then each employee, of course, they're gonna be able to buy more things in the community, which creates more jobs. And so that's such a smart approach to things that really almost every hospital should be able to do, especially when it does even create savings. You're actually spending
Yeah.
less money in state, which is incredible. Do you think that being an engineer and taking kind of a systems engineering approach to things has been beneficial? I mean, we're seeing some of this increasing in healthcare. We have masters and PhDs in healthcare systems engineering just starting to come out, but
Yeah.
that's still a new kind of cutting edge. Do you think that's why you've been so successful?
Yeah, yeah, I mean, it's in line with something I've been saying in the last, I would say, at least a couple of years. When I've talked to like other PhDs, um, you know there was this entire study called, I mean, a field called systems design, in the last 20-30 years, wherein you look at systems, the interfaces, and things. It's not a really an engineering concept, but it's more of the way you start building things at a macro level. It comes naturally for an engineer who's been who spent years in the industry, for example. So systems design is a philosophy, I feel, uh, that we have kind of gotten away from, and we don't focus so much. I'm not sure if it's just the way we have progressed as a society, with with the advent of mobiles, smartphones, having information at fingertips, people have like the instantaneous access to everything. I mean, if it has kind of diluted that focus we had on systems design. I mean, there's beautiful books written, there's patterns, models that are available. I think as an engineer, a trained engineer, over time, it's really helpful for me in problem solving. And I would put it at like the systems design concepts. That's, I would say, a philosophy I want to encourage people to even look at.
Yeah, I just started last week a systems kind of engineering and systems design course for that exact reason. And one of the things I'm wondering is, do you think, and this will kind of be the last question, when it comes to making some of these decisions regarding how hospitals can invest in the local community, what is kind of the best method for finding that information, especially when we're talking about maybe an institution less resourced than Rush, maybe in a smaller city with less financial resources, maybe less experts as well. I mean, you're very well educated and have a lot of experience. A lot of institutions have struggled to get individuals like yourself, right? Where can they figure out how to do that? Should they look to AI? Should they just go out in the local community? Any advice there?
I would say, I mean, it's not an individual's role or job. I mean, one of the, I think the philosophies I've been pushing is out when we have had during this conversation is partnerships. So uh, if we succeed as a system at Rush by partnering, like at least on health equity itself, it's not just us. I talked about West Side United. We partner with community-based organizations, other health systems, and CBOs, faith-based organizations. So it's a matter of partnerships. So if there is a smaller institution, we take a look at this anchor mission network that Rush has been instrumental in creating, I think, 2017, 2018. And we have kind of donated our playbook to this anchor network. It's readily available, and there's this best practices, and so you can take a look, incorporate it. And in terms of I would say finding the right personnel, that's a major challenge the industry is facing. I mean, rural healthcare, when you look at it, right, it's access is a big issue. And when we
Yeah.
look at when we look at rural healthcare, mobile clinics, like you have those vans, like public agencies, CDC, CMS, state agencies, they're all looking at like mobile clinics, but also a paradigm that's become kind of growing. I mean, it was a major necessity during the pandemic. It's telemedicine and the entire telehealth concept. So, in many ways, you see systems are now incorporating what you call virtual care and the paradigms, and a lot of innovation is happening in that area. You don't have to literally look at artificial intelligence to think, oh, is that all innovation is happening? This push towards virtual care across the industry, and this is to solve some of the problems we have in terms of access, and also access to specialists, challenges with clinician burnout and others. So I feel care needs to be provided to patients where they are, how they are, and what they are, why they are. All of these questions. We don't need to force the patients to adhere to certain, like structural constraints that health systems had in the last, I don't know, 50 years and more. That driving to big buildings now with the advent of technologies and the availability of telemedicine and telehealth. I mean, there's a lot of innovation in remote patient monitoring, for example. There's a lot happening in healthcare, and that's why I feel very fortunate to be at the crux or the intersection of all the transformation that's happening in the industry.
Well, and we were fortunate to be able to speak with you and get a lot of a lot of this really valuable information. I like the approach. I think it's unique. I think we're definitely going to try to get one of the shorts from this episode on that community based investing. I think that's really important. Invest local, build local. That's just, we've spoken with a lot of people doing innovation, and I think nobody's really put it in that exact way before and explained it like that. And so that's a really unique approach that Rush is taking. Really appreciate you coming on, Anil, and explaining and exploring that with us. Thank you for your time.
Thank you for having me. Have a wonderful day.